Principe is on the line with me today, and on behalf of Starling Advisors, we are delighted to be at today's final session. We've really enjoyed getting to understand and getting to know your projects better, and hopefully, some of the conversation and some of the information shared here through this learning collaborative has helped you think through some of the next steps with your project back at your sites. We are going to spend a little time today doing a little bit of a debrief from last session and the case study discussion. We really appreciated the input and participation of folks during that session, and we got some good feedback during the session evaluation that we want to touch base with. And then we're going to dive right into our group presentations, and we have four of the cohort participants who submitted their materials for today, and we'll walk through in a minute who's going to go first on that. But first I want to just get us started. I want to talk a little bit about some of the group discussion that we had, and I think, Andy, actually you wanted to walk through this piece before I kick everybody off for the on the other discussion.
Sure. So I'm just going to do a quick recap. We did get some homework entered into the survey system this week. And, we wanted to talk a little bit about some of those results. I'd start by saying the most important part of last week's case study was really to help folks understand that the environment that we operate in is going to be a little bit different in each of our cases, but there are some commonalities in terms of what networks might need to be thinking about in terms of how they create and define their infrastructure to support triple aim goals of payment change and payment reform. So in the case study, we walked through a variety of environmental factors that are very realistic scenarios and asked you to think a little bit about how those same type of factors may or may not impact your own community, how you would respond to those various factors, and the kind of the implications on planning and costs as you prepare yourself to deal with some of those environmental factors. So just in terms of we asked folks to talk a little bit about environmental changes that they see really kind of driving a conversation around collaboration specifically aimed at addressing some of these situations. And the two that were most prominent in the responses we got were the influence and the expansion of managed care organizations in Medicaid, and the other was the need for sustainability in the face of declining reimbursement. And of course, these are two common trends that we see throughout the country as really being drivers of this very conversation that we've helped to facilitate over the course of the last several weeks. So it wasn't surprising to us that folks see some of these, these significant trends, and certainly managed care as a mechanism for administering the financial resources associated with the Medicaid program brings new and interesting opportunities, as well as some threats and challenges to the work that we do. In terms of declining reimbursement, I think that certainly different sectors of the safety net will experience different impacts around this in different ways, and we know that there are a variety of challenges anytime you're trying to change really the economic profile of healthcare, specifically initiatives that are designed to rein in costs or control costs. And certainly I think networks have discovered that payment reform can both exacerbate that problem, it can really put it front and center, and create some concern for financial viability of existing models. But in many cases, it can also, really have fundamentally positive changes on how we deliver care. So if those changes in reimbursement are coupled with opportunities to loosen some of the restrictions on how we deliver care, how we interact with patients using technology such as telehealth to engage in patients in much more efficient ways or access specialty care in much more efficient ways. These are some of the impacts that the challenge around reimbursement are helping to drive. And I think that'll come through today in some of the presentations that you hear. In terms of the types of networks or entities that should be involved in leading these initiatives, I think the answer we got kind of is representative of the folks on the phone. We had some hospitals saying, we're reasonably well positioned to lead an initiative like this in cases, around health centers, specifically federally qualified health centers. They really saw a role for natural convening networks, like organizations that already, function in some way like a network, like a primary care association. And similarly, the hospitals felt like a hospital association could play a role in essentially convening and leading this type of initiative. We also had some folks say that there are some collaboratives that really cross different sectors of care, really focus on some specific improvement areas. In this case, someone suggested a heart stroke collaborative could play a role in influencing how providers in that community work collectively towards a common value-based healthcare-related goal. And of course, some clinics said, look, it's really our responsibility to be kind of at the forefront and leading our response to this change. We, and we've encouraged all the groups that we've worked with over the years that oftentimes the solution that will emerge and be presented to you may not be the one that you're interested in, may not be the one that you think is most effective. So, we would encourage you that even if moving, aggressively in the direction of forming a network for this purpose is not yet in your cards, that certainly understanding why groups are doing that based on some of the environmental stimuli that exist, so that you realize that at some point that eventuality may become more likely. Go ahead, Amanda. Or maybe I can advance. Let's see. I can advance. Yep. We asked folks to comment on some of the biggest challenges they saw in utilizing a network. And the two most common responses were creating the shared infrastructure and shared services, as well as building effective governance and management structure to be responsive to the needs of the whole group. Excuse me. I'm going to comment on the first one first. I think herein lies one of the most fundamental challenges that groups are facing all over the country, which is they see value in working together, whether that's reducing the cost of certain services they know they need to acquire, whether that's developing a capability that they otherwise couldn't do alone, or whether that's capitalizing on things like health information technology and the data that is produced by those systems. There's perceived value in working together, but it's complicated and it's challenging. Organizations that want to work together would benefit from having more consistency in the electronic health records and other health IT systems that they use, but it's not an easy process, nor are all organizations willing to move to another platform. So how can we look at opportunities to deliver shared services while dealing with the reality of the environment that we live in which case we have a lot of variability between our individual sites. That's a fundamental challenge. It's something we hope that some of the groups today kind of comment on as they talk through their thoughts around developing some of these programs. And there is no one-size-fits-all answer here, except to take you back several sessions and really talk about being very deliberate in planning which shared services are going to have the most value, but also defining a set of standards for a network that can evolve over time. So maybe it's not everybody has to buy into a shared data function right out of the gate, but if in the 3-year or 5-year vision for the network, that becomes a critical component of how the network's going to derive value for its payers, then knowing that over the course of 3 years there's work to be done makes a lot of sense. We hope we've provided you with some guidance on effective governance and management structures. Again, there's no magic bullet or single answer that's going to work in all regards, but we do know that part of the benefit of working through these networks is, in fact, creating a defined governing model that really steers the activity and the infrastructure in the direction of value, and doing so with a group of your peers, with a group of like-minded organizations, or with organizations, other safety net organizations that aren't the same type of organization as you are, really helps bring the expertise necessary to the table to make this work. And our experience with the safety net, I think most people who have operated within the safety net for a long time really do value that kind of local connection to the work. And so networks represent an opportunity to create a governing body that has a lot of experience and on-the-ground knowledge and know-how working with the very populations you're working with in terms of steering these types of initiatives, versus, for example, allowing an out-of-state, for example, managed care company really be dictating essentially how care is provided. So it's a defensive strategy in making sure, governance that is a defensive strategy for making sure that a local voice is being heard and really being effective in designing local solutions. Some of the key challenges and opportunities to address those challenges that were cited, first was having meaningful conversations with payers. I was just having a conversation today with someone, and that person was saying to me, look, I really feel like 10 years ago our relationship with these plans was much more adversarial, but I really see now how that needs to be much more of a partnership, and how we are actually experts in how this care should be provided, and they're willing to listen, but we have to engage with them. That means sharing with them some of our thoughts and our plans and our aspirations, being very honest about where we do and don't have the resources to move forward, sometimes and often being open to compromise in terms of how their set of solutions might complement our set of solutions, because in the end, if we can align our, we can never have a perfect alignment between the mission of a payer and the mission of a provider, but we can certainly work together to align certain aspects, and that really should be around the patient and the triple aim goals. Bringing in and working with experts, of course, makes sense. There are a lot of emerging best practices in how to do this work, how to structure these networks, and how to take the most, generate the most benefit, the most opportunity for investment in the safety net. Effective board models, as we just discussed above, that support clear participation requirements really represented an opportunity, and as we discussed earlier, can start down a path of becoming more standard, more efficient, leveraging greater scale without it having to be a very disruptive change. And of course, as this has come up in a couple of the homework exercises we've asked you to complete, it certainly would, I think, feel a little easier to pull some of this off if we had a greater level of interoperability. So does that necessarily require us to all be on the same EHR, or at a minimum, does it require us to really think through what interoperability means, and the implications of this in terms of how we evaluate performance, but also the implications in terms of how we exchange information in real time to support the patients that we serve. And again, I think you'll hear some examples of where addressing this particular challenge, the IT and data challenge, really create a value proposition for the network and allow us to do some things by collaboration that we aren't capable of doing independently and on our own. I've talked for quite a bit. I did want to kind of run through those, and then I'll stop here and see if folks had any questions or additional comments they wanted to make. We thought the online discussion was pretty robust. Okay, I am then going to move to the last set of questions. So do you feel prepared? And we hope that this was an opportunity to at least help you understand the models that are out there, why they've been developed the way they've been developed, and the overwhelming response we felt was folks generally felt prepared to dip their toes into this at some level, that these webinars have been helpful in doing that. But that they identified that there are new skills and therefore potentially the need for new staff in order to address those skills. And this is something that whenever we are working with a group who's at the early stages of network formation, at the end of the day, none of this happens without people and talented people who understand the vision and know how to execute it. So staffing for success is critical. It's, of course, one of the primary reasons why these initiatives take investment in time and money, but certainly represents a key piece to the success of any potential network. And this group is a pretty diverse group in terms of the fact that some have gone pretty far down the path of forming and are operating now in network models. Others are really just starting to think about that. And I'll just remind, based on this person's comment, I want to remind one thing that we said at some point early in the process in the discussion, which is our opportunity to do this work in relatively safe environments doesn't necessarily last forever. At some point, if value-based contracting through value-based vehicles becomes essentially a requirement, which is, in my opinion, starting to feel like it's getting pretty close, it would have been wise to have done so and dipped our toes in the waters into some relatively safe models so that it's not a big transition all at once, again, that would have the impact of being disruptive. So in your community, in your area, are there ways to really get started with some things that can have a big impact but aren't necessarily majorly disruptive? For example, in a lot of our work with safety net providers, we do often look at smaller segments of their payer mix and say, look, if we were to test something in a population of patients that only make up 5% of our payer mix that's relatively safe, it gives us an opportunity to work through some of the kinks and some of the issues without doing it in our Medicaid population right out of the gate, for example, where it's impacting 60% or 80% of our patients. And so I think this comment about the ACO, and I think specifically, I'm assuming means the Medicare Shared Savings Program, ACO, really forced this group to the table to think through some of the very issues that we've laid out throughout the course of this session in a way that that really has put them now in a good position to take those same learnings and reposition them to other aspects of the care that they provide. So a good opportunity, things being a good opportunity to lay some of the foundation for accomplishing this work. With that, unless there are any questions, I'm going to turn it back to Amanda, who's going to facilitate the presentations by the groups.
Great. And so we did put you guys in an order. And so we're going to start out today with a discussion from North Country Healthcare. Then we'll move to the Primary Care Coalition of Mississippi, Kearney County Hospital, and then the New Mexico Park Project. So we're going to start there, but and we have your presentations uploaded. Was there anybody else who didn't send their presentations in advance who wanted to share their presentation, and we can, AJ and I can work to get those uploaded and on the screen? Did we miss anybody? Okay. So with that, AJ, does it make sense then? Should I plan to advance those slides for folks? I'm assuming folks don't have the ability to advance their own slides. Is that correct?
Yeah, and this is Annie. We had decided that we'll do that for the folks.
Okay. Okay. I'm sorry. I was noting on that. Okay, no problem. So we're going to start then with North County, or North Country, sorry, healthcare. And if you could, whoever's doing the presentation, just remind us who your team members are, introduce yourself, and we'll get started.
Good morning, this is Kimberly Chen. I'm the Director of Pharmacy at North Country Healthcare. Today I'm joined by our Chief Operating Officer, Marty Neff, our Deputy Chief Medical Officer, Dr. April Corona, and our Business Office Manager, Link Pearson. Participating normally, but absent today, are Amanda Gay, our Director of Outreach, and our Chief Medical Officer, Dr. Cindy Martin. So I'll go ahead and start our presentation. So our presentation is around negotiating a DSRIP. And what a DSRIP is a delivery system reform incentive payment strategy. Arizona is starting to design one of these for the Arizona Healthcare Cost and Payment System. We call it ACCESS, which is our Medicaid program. The district is designed to improve care coordination among multiple agencies and multiple providers with 4 identified vulnerable populations. Those populations are incarcerated patients, American Indian, children with behavioral health needs and engaged in the child welfare system, and adults with behavioral health needs. The vision for this program is to align North Country with our partners, and the partners include a variety of folks, providers, the district entities, MCOs, Access, and those who need to provide the core health services, including REBA, which is Regional Behavioral Health Care Association, and Altex, which is another provider of mental health services. Heavily influence the Care Management Collaborative and incentivize independent practice associations rather than alternate mechanisms to benefit both the patient and the independent practitioner. We really want to be able to have a large influence with who the district entity should become. North Country, through this process, is really engaged in whether or not North Country should be the district entity, and have decided that really it's not in our structure to be the leading agency, but we want to have a large role in the conversation on how this works, because some of the target populations we're strategically positioned to provide the best services. The purpose is obviously to have that major influence, and the shared services that we would be engaging in this district would be to be the analytics, the incentive payment methodology, and care coordination planning and activities. The next one is our model of the program that, if you want to advance to the next slide. This picture should look very similar. It's the Independent Practice Association model. The Board of Managers would include 3 federally qualified healthcare centers, North Country, Canyonlands, and Yavapai, specialty providers, social services, and HICIT. HICIT is our Health Choice Integrated Care, used to be the Guidance Center, so they're a mental health component to the program. And then we also intention to include other providers such as social services to engage in the services that they can provide best. So for example, Verde Valley Social Services for patients here in Arizona, actually for patients who are discharged, they go to the home, they help the patients move back in, they clean out the refrigerator and remove bad or unhealthy items and provide fresh, new, healthy foods. And what is that to us is a better way, what better way to wrap around the healthcare model than to include these organizations that are positioned to provide those services that healthcare organizations traditionally aspire to do but don't have within their capability and capacity to really do that. Another example is the reentry programs for incarceration. Social services is far better positioned to help with some of these non-medical needs that have such direct impact to patients' medical care. The rest of the model should look very familiar to everyone. We would continue to have a full IPA membership and then divide up into those subcommittees. If you want to advance to the next slide, we really are in the very early stages of this process. Really, this collaborative has helped us to focus in on this conversation around should North Country be the district or not. And so our biggest challenge list is quite lengthy, as you can see. We highlighted the key things, which the first is to reach an agreement on who would be the district entity in northern Arizona, given that North Country doesn't feel that we should be the one in that seat. And then to determine how the entities will engage in that data sharing and analytics to come upon an agreed shared clinical and financial measures with this vast of a body of providers. We definitely have already seen challenges as we begin the discussions with those entities. Obviously, developing shared clinical and administrative protocols will also provide challenges. What we found in our area is that it's a very patchwork coverage around care coordination. But what we're finding is that, as the last item indicates, is it's really unsophisticated, and there's a lot of overlap. So there's big holes in that patchwork, and then there's a lot of duplicative work being done. And so those shared clinical and administrative protocols are going to be key, but also very challenging to have organizations look at how they provide care in a different way with the faith and trust that the other organizations are going to live up to their end of the agreement so that there isn't a disruption in the patient care that they used to be providing. And then, as you may have noticed on the very first slide, I forgot to point out, but we have a ginormous geographical area. We have 7 large rural counties. It's spread all across northern Arizona from the New Mexico border to the California border. And so not only are we dealing with a variety of different health partners, but it's also not just one county or one area. So we may have to deal with multiple social service organizations, multiple specialty providers, all providing the same type of specialty care, but in different regions, which just adds another layer of challenge that North Country is used to doing because we are spread out over northern Arizona, but these other organizations are not necessarily used to collaborating.
576 miles.
My chief operating officer is adding that it's 570 miles across from north in the area that we're talking about. And then really the last challenge is to adapt to this each of these 4 vulnerable populations because, as mentioned, they're all very unique and distinct, where you're not going to necessarily apply the same strategies from an incarcerated patient to a child with behavioral health needs engaged in a welfare system. So it just continues to add those layers of challenge because you're not creating a model that is a one-size-fits-all. Really, the final slide, if you'd like to advance, is our next steps. And again, as I mentioned earlier, we're really in the beginning stages of this. We do identify that the IPA model is the right one for us. We want to use the IPA model not just for this district collaborative, but it would be to begin to build that foundation for other work around what North Country is involved in. And so we need to determine the feasibility of that IPA while negotiating the joint risk-based integration care model, but not limited to just this district program. We also need to identify the members of the organizations to partner in the IPA. For the district, it makes sense that we've identified some of them already, the other federally qualified healthcare centers. And then really the last 2 are the formalization of the IPA, the legal structures, governance, and formal agreements. And lastly, just negotiating the progressive contracts to provide optimal care. And, a lot of what was just spoken about earlier this morning is just that trying to navigate making those relationships beneficial to all parties while not compromising patient care. And that's really where North Country is beginning the conversation. The last slide is just kind of some pictures of some of the dynamics that North Country is engaged in. We do have a mobile medical unit and are involved in a lot of different communities. And so we're used to challenges, but some of these seem larger than others. We're really excited to begin engaging in the conversation and expanding what kind of patient care opportunities this collaboration might bring. So I think with that, any questions, or did you want to, are we going to go on to the next presentation?
No, I think let's stop for a second, and I'd like to go back and hear from the group. And don't forget, I can see you guys on the screen, so I'll call on you if I don't hear from folks. But want to go back just for a second around some of the challenges. And I think a lot of the things that's been highlighted here by North Country are probably similar to some of the challenges that other groups are facing. I'd love to hear from some of the other cohort members, you know, if any of these challenges resonate with you, and if so, what are some of the thoughts that you've had in terms of trying to, mediate some of these challenges?
This is Beth in New Mexico, and I don't have any suggestions for mediating, but this is an amazing presentation, and this is very helpful to me in how we think about the work we are hoping to do here. And I guess my primary question is, how did you decide on an IPA?
That's a great question.
That's a real,
yeah.
It was a really great question, and we had to really consider here at North Country who we were considering to partner with. And I think for us, the conversation involved also around some of the billing strategies that we were looking at, and what kind of, really for us, it kind of came down to the board structure and wanting to have an equal vote, because these organizations and partners vary in such size. Access is, across the whole state. This district entity is supposed to do a lot of work, and we knew that whoever was going to be the driving entity couldn't be the one to hold the larger stakes in the game. Our past experiences with an ACO model, we are involved in an ACO, have been that we don't have a shared voice as much as the larger entity that's kind of the lead on that. And so the independent practice the association really resonated with us to make sure that, regardless of the size, even because amongst the federally qualified healthcare centers, we vary significantly in our patient population and our infrastructure, but really that collaboration of the equity really resonated with what we felt would help us to advance these practice models and get others on board because they would feel that they had an equal share in that conversation.
I want to also add, this is Marty, I want to also add that our homework assignment, I think the last time or the time before that, really solidified our feeling that the IPA was the right choice for us. It just made the best sense.
And I'm sorry, this is April. I was just wondering, in New Mexico, what kind of organization are you associated with? So the project in New Mexico is 4 very independent hospitals, all located in the northeast quadrant of the state. So they've agreed to look for ways to work together, but we do not, at this time, have a vision for creation of an IPA. We will not integrate finances because of there are several structural barriers to doing that. We are looking at clinical integration for select services, but that's as far as we've gotten. And we're hospitals. So are you all FQHCs?
Yes, right now, the folks that we would be looking to engage with would all be FQHCs or independent private practices, specialty groups, not any social services, but not any hospital systems at this time. We have other partnerships with them in other activities, but especially for this specific district and looking at other projects moving forward, it made more sense for us because of our target population being the uninsured and underinsured. We're more engaged typically on that patient level as safety net providers outside of the hospital systems in our areas.
And across our system, there are 9 hospitals across in the different regions that we are located.
Okay.
And that would be the last piece that sort of made it a little daunting to try to approach some kind of model that also took on 9 hospital systems was, I think, didn't answer the question of this DSRIP request from our Medicaid program.
Okay. That's very helpful. And for us in the northeast quadrant of New Mexico, there is a very limited F2HC presence, and leave it at that.
I just want to ask a question too to the larger group. This is Amanda from Starling. You guys hit on something that Andy and I encounter frequently in the work that we do with groups, which is this idea, and I love the way you phrased it, this patchwork coverage for care coordination. You know, in our experience, organizations and networks and individual providers really define care coordination and care transition and care management in a whole different set of ways. And I'm curious as to, and maybe it's too soon, but certainly DSRIP will define some of the parameters for what that is going to look like. Have you guys given any thought or have any concerns about how you're going to do any kind of assessment on what's going on with this patchwork and how you might look to close some of the gaps? And if there's any of your cohort members that have had to address this, and I'm thinking, you know, primarily some of the folks maybe in Kearney who are a little bit further ahead with some of the work they've done with the ACO or the F2HC group in New York, you know, that might have some insight into this as well. I think this is a huge challenge for groups as they're coming together, and I would love to hear both from North Country as well as from others about how to address and think through this challenge.
Amanda, that's a fantastic question. You know, we've started to grapple with that. I don't know that we've come to great answers. You know, I think the challenge is that as all of these independent practitioners, whether it be social services or HICIC or, you know, behavioral health, we all are targeting our care coordination efforts toward the highest risk, highest utilization population, which causes there to be redundancies in our efforts. But because of the different impacts of not having those efforts held within your, you know, not being done, there's financial implications to each organization. And so we've really wrestled with how do you convince organizations to work together to relinquish control over maybe some of the coverage of that care to then be able to expand capacity without putting your financial well-being in the hands of another group which you don't have control or oversight over. And so the DSRIP proposal that, or the request for proposal that's out right now does have some parameters outlined that going into it, there must be some predetermined quality measures and plans laid out. And I think that what we've learned as an organization in going into these types of proposals is that we do need to look at the endpoints and then work backwards from that we need to determine the quality measures and then create the plan to get to that point. And I think that our conversation has largely been around, as we engage with other organizations, determining how we can create monitoring that provides that confidence that the work isn't being left to someone else and then the ball being dropped. And so the specifics of how that works hasn't come to play yet, but I think the idea is around that we'll have to design sort of internal monitoring and reporting structures within the organizations to ensure that when one organization is saying, I would normally provide care coordination to this population, but I understand that your organization is also doing it and better equipped, so I'll shift my focus to a different area, that they can then still maintain confidence that their patients in that area aren't falling through the cracks. Does that sort of answer, I think, the question that you're getting at?
Yeah, and I think that's a really great way to approach it. And I mean, if you think back to some of the discussion that we had, you know, several weeks ago around this idea of building clinical programs, I think it is really important to stay focused on what the most important clinical outcomes are and what the appropriate clinical and, general workflows need to be in order to support that. I think sometimes there's this propensity to try to over-engineer that, and I think, really targeting those resources and those efforts around what's going to be outlined, whether it's in a payer contract or district agreements or whatever the case may be, I think is really important. We see groups struggle with this all the time, and so, I think it's really helpful to kind of hear how folks are approaching that. I guess, I know we need to move on to the other groups, but I just want to give everybody another opportunity, including AJ and Andy, to kind of weigh in or ask any last questions before we transition. I think this has been an excellent discussion, and I think it's really helpful to hear kind of, even though you're at the nascent stages of this, that you've done some critical thinking and some due diligence around how you're going to work together to sort of structurally and functionally respond to the opportunity in Arizona. So other observations or questions from Andy, ASU, or the group?
I'm okay, Amanda. Thank you.
All right. Okay. Thank you guys so much. And please stay in touch. We're really just, from the perspective of seeing how district rolls out in different states, Andy and I are always looking for examples of, how groups are overcoming some of the, hurdles of putting these programs and these, this kind of infrastructure in place. And we'd love to sort of continue to hear from you guys as you evolve down this road. So definitely, you've got our contact information. Please stay in touch with us. We'd love to hear how it's evolving for you. So with that, I think I'll turn it over to Joseph and the folks over at the Mississippi Primary Care Coalition.
Yeah, thanks, Amanda. So I am Joseph Grice. I'm Director of Technical Assistance and Training at the Mississippi Primary Healthcare Association. And so we'll be talking today about the IPA that we formed a few years ago. It is the Primary Care Coalition of Mississippi, and it's sort of currently basically a virtual arm of the Primary Care Association. So the Primary Care Association is the state trade association for FQHCs, and we only have FQHC members in our Primary Care Association. And so a little over 3 years ago, three and a half, 4 years ago, we decided that, or our health centers members decided that they wanted to form an ACO, Medicare Shared Savings Program, Track 1 ACO. And so to do that, the PCA decided to develop an IPA and let the IPA be the vehicle by which the health centers participate in the ACO. So we have 21 FQHCs in the state, and starting in 2014, 14 of 21 health centers were participating in the ACO. We sort of had this development, IPA development conference call, and sort of officially, unofficially, a few more health centers were involved in the IPA. A couple of those were not able to join the ACO because they were part of an existing ACO. There were 4 health centers who were already in an ACO that was kind of stumbling and not really functioning well, and they eventually were able to come over to our ACO when CMS disbanded their ACO. But on the front end, they weren't able to join the ACO, but they wanted to be involved in whatever the IPA was doing, which for 3 years has basically been nothing but the shell by which the ACO functions. And so the ACO has a partner by the name of Collaborative Health Systems. They're a wholly owned subsidiary of Universal American. And so they kind of run the show in the ACO. They basically run all the operations. We do have a management committee made up of each health center who is involved in the ACO has a seat on the management committee, and then Collaborative Health Systems also has a seat there. the PTA has a seat on the management committee, but it's a 0% vote seat, so it's basically ex officio. But we have a voice there. So, so right now, basically, the PTA has no operational infrastructure. The Primary Care Coalition of Mississippi, the IPA, has no operational infrastructure. We don't really have a board of directors, management committee, anything like that. We didn't get that far. We just created the shell, created this legal entity, and it's just there for the health centers to participate in the ACO. But we knew on the front end that the IPA had many more opportunities ahead. We knew that this was the vehicle by which the health centers needed to be involved to participate in several other types of agreements, contract negotiations, and so we sort of we understood, and our health centers understood that was the direction we wanted to go. So the goal of our network is to just right now expand upon what we already have. We have this foundation, we have this shell, and we want to accrue the broader set of benefits to both the health center members, to both and the PTA also. We want everyone to benefit. We know that to benefit, there has to be some work on the part of all of the members. And so sort of the first step here is moving beyond this basic foundation. And so let's go to the next slide, Amanda. So just a quick look at our current state environment. We have 2 Medicaid managed care plans. That number is probably going to go to 3 within the next year and a half. That's kind of what we're hearing from Medicaid. There are 4 ACOs currently operational in the state. Our ACO is the only FQHC ACO in the state. Some of the others are hospital involved. I think maybe all of the others are hospital involved. We don't know a whole lot about the other ACOs, but we know that there are 3 others. And there are a couple of MA plans. Again, we don't know a whole lot about those. Our health centers have a few contracts, and we've started to look at some of the contracts they have with the MA plans, and that's a little bit of what the IPA is starting to do going forward. Looking at Medicaid managed care, it's basically they're focusing on disabled children and adults, low-income adults with breast and cervical cancer, foster care children, and then we have our capitated Medicaid and just the basic perfunctory Medicaid. And then just a quick point, there is a state plan amendment for Medicaid to preserve the PPS, and they also wrote in there an APM that hasn't really been actualized. It's not really what we would think of in the national scheme of where everybody's going with APMs, but Medicaid has some thoughts there. Not really where we want to go, but just interesting to point that out, although nothing is really happening there. So we can go to the next slide now.
You know what, Joseph? Those are the only slides I had, unfortunately. Yeah.
Okay.
Yeah.
That's okay. Well, I'll just talk through the rest of my slides then.
Okay. Yeah. Sorry, that was all that was submitted, and I don't know if there was an error in the transmission, but sorry about that.
Yeah. No, there were 3 other slides, but that's okay. No worries. I can talk through them. I have them in front of me. So a little bit about the expansion of the network. So like I said, we want to enhance the benefits for everybody that's involved. And we're thinking that we want to do that through a network MSO partner. We have actually put out an RFP, and we've gotten a few responses to that RFP, and we're thinking that's probably going to be the best way for us to go moving forward. So we'll probably act on that RFP here within the next couple of quarters. and we'll see what happens there. But it just seems like that's the most feasible at this point, as opposed to trying to run everything out of the PCA. The PCA would definitely have a strong involvement. The PCA is integral in the IPA moving forward, and we kind of have to be. It's kind of it would be a little bit disjointed. We feel like if an individual health center or a few health centers were kind of moving this forward. So the PCA is playing that role and will continue to play that role. But we need this. We need an MSO partner to run things for us. We want to define standards for member participation along with a value proposition. So we want health centers to tell us what they want to get out of this. We want to know what their benefits could potentially be. But there's also standards for participation, and that's something that's going to have to be probably continually revisited, whether that's yearly or even semi-annually, quarterly. But it's something that will definitely have to be looked at by the board of directors or governing committee. And then we'll also want to revisit membership eligibility and talk about membership expansion, whether or not our health centers want to allow non-FQHCs to become a part, and whether that's sort of associate members or, we haven't thought that out, but we want to leave that open. So far within the ACO, we actually had an opportunity last year to bring in some out-of-state FQHCs into our ACO, and our health centers didn't really want to do that. So I feel like that's probably not somewhere where our health centers will move as far as inviting non-FQHCs in the near future. But I think that we have to leave that door open, and I think that definitely it needs to be part of the conversation. So a little bit about our challenges that we experience. Really, the biggest challenge is just the assessment among our existing members and getting them to articulate what their need is and their desire to buy in on the benefits of moving beyond just our horizontal-only network and really getting the ball rolling. We have meetings, we have presentations, and we have not a lot of feedback from our health centers sometimes, and so we that's a big challenge. We need to hear from them. We need to hear their voices. We don't want to speak out of turn for them. We want to do what's best for them, but we want to know from their perspective what's best for them. And everybody always says that if you've seen one FQHC, then you've seen one FQHC, that they are really cut from different cloths a lot of times. And so, you can't stereotype based on one vocal member of the IPA. So that's a big challenge, just hearing back from our existing members and seeing where they want to go. Again, as I mentioned, Medicaid is going to open up bids for managed care in January 2017 is what we're hearing, and we do expect that there will be a few bids. We've heard of 3 or 4 organizations who want to bid on that, and we're expecting that Medicaid will keep the 2 they have and then add 1 more. And then another challenge is just the timing. We've been really trying to move this forward within the past 6 months, and I think we've come a long way, but 6 months has flown by, and it just feels like time really flies because the PCA is doing its PCA thing. Health centers are doing their health center thing, and this is sort of another thing thrown on the plate of everybody, and so time flies when you have so much to do, and so that it's a big challenge that time is getting away from us, and we really want to solidify the MSO partner and move that forward. And then just real quickly, a few next steps that we're looking at. Obviously, meeting with legal counsel to review where we are and just to ensure the right movement. And that's a little more complex than just going out and picking a lawyer. You know, you have to find legal counsel that that knows about this environment, that has worked in this environment, and really does have a grasp on where our health centers need to go, what's best for our health centers. We want to have continued and ongoing dialogue with FQHCs and the HCCN. We've really, the HCCN is separate from the PTA in Mississippi, and we've really strengthened that relationship here in the past few months. And I think moving forward, the HCCN will play a really important role in the IPA, you know, with whether it's data aggregation or there are several things that we feel like the HCCN could help with, and we really think that that's going to happen. We want to continue to look at MCO contracts. The plans have different contracts with different health centers, so we want to look and sort of contrast and compare the different contracts and see how the plans are really treating each health center, you know, whether they're taking advantage of certain health centers via their contracts. And so we really want to open that up and look at that. And then just, again, have this talk about membership changes where we want to open up the door for membership of non-FQHCs. And then, obviously, just award that our RFP. That's really probably a very near future step that we want to take, and it's going to be a really big move for us. So that's all I have, and I'll be glad to attempt to answer any questions. Janice, our CEO, was the primary builder of our presentation, and so I'll do my best to answer any questions on hers and our behalf.
No, I think this is really helpful, and it's really interesting, Joseph. You know, Andy and I have worked with you guys in the past, and it's really interesting to see kind of how this is really evolving to try to respond to what's going on in the state. I have a couple of questions, and then I'll turn it over to the group. You know, one of the things that I think we touched on a little bit in some of our discussions around governance and management structure was this idea of a third-party administrator or some kind of an infrastructure partner. I know you mentioned the work that the ACO is doing in partnership with Universal American, and now the IPA itself is looking at sort of a similar arrangement with some kind of an MSO partner. Can you talk a little bit about, if you're comfortable, talking a little bit about what you see as some of the benefits and trade-offs of looking at, you know, basically contracting to have that type of infrastructure in place, and what were some of the maybe discussions that you guys had as a group about that sort of the benefits, you know, advantages and disadvantages of going that way? It's a model that we see a lot of groups looking at. We think there are, you know, a lot of advantages to it, but it comes with it also some things that you give up. And so I'd love for this group to hear a little bit more about, you know, some of the churning that you guys did, either through the arrangements with Universal American and your ACO, or some of the things that you guys are thinking about as it relates to the MSO support of the IPA.
Yeah, absolutely. So our relationship with Universal American through the ACO really has been a little bit of a roller coaster. There's some really good things about that relationship. Just the expertise that Universal brings to the table is huge. They operate, I think it's something like 25 ACOs nationwide. A handful of those are FQHC involved ACOs. So we're a little bit of an experiment as far as them getting into the FQHC conversation. That actually has been probably more beneficial for them than it has for us, but it has been good. I would say overall good. The trade-offs of this relationship is that there definitely feels like you have a little less involvement, a little less say in what's going on. In all reality, you don't. CHS or Universal American comes to the table with a 23% vote on our management committee. So our health centers control the rest of that vote. So our health centers still have the biggest voice, but Universal American, it's a weird percentage, but within the operating agreement, there's a sort of a cutoff of supermajority that they could sort of block something that didn't look good on their end. So that's where the odd number comes from. But so that's a little bit of the trade-off. Again, though, it's the good that they bring to the table, I think overall outweighs that downside, that trade-off, just their expertise. And working with CMS, they have the ear of CMS in DC. They have meetings with leaders at CMS, and so that's really advantageous for us. To have that channel, to have that conversation. They have been integral in some of the conversations with CMS around the changes they've made, which allow nurse practitioners to attribute beneficiaries to your ACO. It's not exactly where we want it, but it has helped. That conversation has helped FQHCs a lot. What is interesting, so the RFP that we have out for the IPA, for the MSO, for the IPA, Universal American is also, they're actually bidding on that. So they want to continue their involvement with us, and they see that there's great potential here, and they definitely are throwing their hat in the ring. We've had some interest from some other pretty big organizations that also see that benefit for them. So that's again a little bit of the trade-off, is that you have these big corporations that you don't want to be taken advantage of. So you have to be real careful. It's a little bit of shaky ground. You really want to have your legal counsel equipped to evaluate whatever they put on the table. You want to have that expertise in house. So that's definitely challenging, finding that type of legal counsel that can advise you on contract negotiations and that kind of thing with the MSO. Because they're not just bidding on the RFP to be nice. They don't want to just be friends. They want to benefit from it also. So you have to be a little bit careful there. But again, the big thing is that the expertise that those organizations bring to the table. It would just take the PCA or the ACCN a really long time to probably get on that level and to be able to operate in that arena. Does that make sense?
It does. It does. I'm interested to hear from the group if they have any questions for you on this, because this is kind of one of the hot topics that I think groups contend with as they think about infrastructure development. So I would sort of turn it to the group for any questions or reflections that you guys might have on this. Okay. And my other question, Joseph, is also another issue that we know groups work on a lot. We talk about it as a pretty integral part of developing a framework for clinical integration and really for being able to demonstrate the value proposition in the network, in the marketplace. And that has to do with the standards for participation into the network. I know you guys are at the beginning stage of this, and obviously, I think we've talked about some examples in some of the discussions we've had, but can you talk a little bit about, as far as you guys have gone in this, what some of your discussions have been about what those standards for participation might look like, how the network might be looking to support them, and kind of how and why you're thinking about the ones that you are thinking about.
So we haven't gotten really far down that road. We have been looking a lot at our ACO data and just kind of seeing where our health centers fall in that arena, where their performance is in that arena. And so we're also looking at UDS data. So kind of where we are right now is looking at where our health centers are, and we haven't really pulled out anything specific to create these standards. We know that these standards will be in place. And front end going in, it's more than likely going to be, do you want to participate? Yes or no. If you do, then you can participate. And then once we're in there, then we sort of not create those centers. That we'll create those on the front end, but really start to evaluate the health centers on how they're performing on those centers that we create. So I don't really have a good answer for you there, because we haven't really gotten that far, other than just sort of taking a look at the data that we have at hand. But it's a huge advantage that Universal American is great about sharing with us all of their data. They do a lot of analytical work on claims data, and so they send us really clean pictures of claims data, and so it's really easy for us novices to look at that. Whereas if we just got a data dump from CMS, we would have no idea what to do with it. So another advantage of having that sort of expertise on that end. But yeah, so where we are right now is we're just kind of looking at where everybody falls.
Yeah, and I think that's one of the things that we recommend to folks. I mean, the idea that you're looking at currently available data, that particularly if you have the ability to look at it historically, clinical data and clinical outcome data can be a really important set of standards to consider. A lot of times we also look at other kinds of operational or clinical capacity things that might be important benchmarks or gateways to participation. So being able to demonstrate things like health home capacity, meaningful use capacity, use of shared data and IT as part of the participation requirements. Those are some of the other things that we often will recommend to groups, or take a look at what they have in place. It's always a good idea, and often a lot easier for networks that are integrating horizontally to identify clinical measures, because oftentimes those groups have specific requirements about what they have to report on anyway. When you start to look at more vertical networks or networks that involve different kinds of stakeholders, you have to think carefully about how you're going to collect and manage those the data necessary to track those participation standards. So thank you. I think that was actually a lot of good information about that. And before we move on to the next group, I just want to see if anybody else has any thoughts or questions about things that you may be considering when you think about participation standards, and or any kind of best practices or things that have evolved as you guys have been thinking about your networks. So this is a question really for the larger group. Okay. Well, with that, thank you so much, Joseph, and the folks from Mississippi. I'm sorry that we somehow lost the second part of your presentation. We'll make sure that we get that out to everybody. We want to make sure that you guys have some real-life examples from your cohort members to draw on as you're doing your thinking. So I'll coordinate with AJ and make sure we get those, the up-to-date information after the session. So with that, I think I'm going to turn it over to Kearney County Hospital. I'm not sure who's on the line.
This is Kendall.
Yep. Hi, Kendall.
Are you able to hear me?
Yes, sir.
Okay. All right. Well, I will do my best with explaining this. I'm here by myself today, and this is something that's pretty new. Excuse me. And I've managed to get to my office without all of my materials. So I will muck through this as best I can. So what we're looking at is we were offered an opportunity to participate in the organization of a new ACO. And this is being driven essentially by the Kansas Heart and Stroke Collaborative, which was created a couple of years ago as a a care delivery and payment reform model, looking to improve the rural Kansas heart health and stroke outcomes while reducing costs. And initially it was set up to try to reduce costs. It's a 3-year grant that's being administered through the University of Kansas School of Medicine. Excuse me for my voice. And the three goals with the Kansas Heart and Stroke Collaborative were to reduce the cost of care for target populations by nearly 2% of savings, which was just under $14 million, reducing deaths from heart and cerebrovascular disease by 20%. And then the third goal was to sustain the project beyond the 3-year grant period. So we've got 1 year left within the Kansas Heart and Stroke Collaborative. So the Kansas Clinical Improvement Collaborative was created to lead this initiative of creating this new ACO that would be a means for continuing the efforts of the Kansas Heart and Stroke beyond the 3-year grant period. So what the proposal is to explore a Medicare shared savings plan with the goals to develop a rural clinically integrated network, hoping to improve the outcomes and lower total costs of care for heart attack and stroke patients, and then having quality improvement and care coordination, which again is something that was being developed through the Kansas Heart and Stroke. And then capturing those savings generated, which would then be divvied back out to the participants of the ACO. And then again, like I said, sustaining operations beyond the grant period. So you can go to the next slide, please. So to participate, they're reaching out to rural and frontier providers because they need to have a sufficient number of physicians to have 5,000 attributed beneficiaries, Medicare beneficiaries. So that will take a significant number. There were 14 hospitals / providers participating in the Kansas Heart and Stroke Collaborative. This will take a larger number than that. They're needing to get it, or wanting to get everybody signed on by September 6th. And this was presented, effort was presented to us within the last 30 days. So it's something that's happening pretty quickly. I guess one benefit of that is that there's not a financial risk to participate, which makes it a little easier to think about signing on. Although we're also considering applying to become a FQHC, and I was just told kind of in passing Friday that might interfere with our ability to participate in this. It's kind of an either or, is my understanding, because it would be viewed as double dipping by the feds. So, or at least that's my understanding. What little bit of understanding I do have. And I can't explain this in detail other than that private practice providers and specialists can participate in some manner. For instance, the majority of the ACO providers are, like ours, are all of our providers are employed by the hospital, which is the case in most instances out in here, though there are some private practices that would be able to participate. So that requires signing a participation agreement that has participants' rights and responsibilities. And I can go into that in a little bit of detail, where the Kansas Clinical Improvement Collaborative is operating the clinically integrated network, and the providers or participating providers maintain really a significant degree of interdependence and and cooperation to provide a high quality of health care services. Excuse me. And everybody's responsible for reporting their data. If a provider is not meeting the outcome measures necessary, of course it would be pulling everybody else's down, but then a corrective action plan would be put in place. And then if that provider continues to be unable to successfully meet outcome measures, then they can be terminated based on non-compliance, whether that would be meeting outcome measures or meeting all of the requirements of the Medicare Shared Savings Plan, which would be that agreeing to participate in MSSP and adhering to the 42 CFR Part 425. You can go to the next one, please. Thank you. So it's really the governance model is a horizontal model. So it's a completely separate legal entity. There'd be an independent governing body that would be made up initially of all of the providers that sign up by September 6th would have a seat on that board, and then overall it would be 75% would be made up of ACO participants. One would have to be an independent Medicare beneficiary, and then they would have fiduciary duty, but not governing anything outside of the ACO. So then again, the providers maintain all their independence in that regard. And then there would be a management structure. There would be a board-appointed manager, and then the chief medical officer, QA/QI professional, and a compliance officer that would also be brought on board. And they'd be responsible for audit record retention requirements and coming up with policy around that and meeting the guidelines set forth in the MSSP. Excuse me, go on to the next one. So some of the biggest challenges are meeting the 5,000 attributed patients. For instance, we're very interested and excited about participating in this. However, we may not be able to. And my understanding is that some that are signed up now are potentially having second thoughts because it may limit them in some other things that they were considering doing. So that may become a very difficult barrier to overcome. I think something else is making sure that seems like always is a challenge with something like this is making sure that everybody's reporting as required and necessary, reporting what they're needing to and meeting requirements. And then through the CMS criteria, you're also required to have a website, the ACO is, and they have very specific, excuse me for my voice, very, very specific requirements around that website. So it'd be making sure to meet that. And then identifying quality people to be the manager, CMO, QA/QI professional, compliance officer as well. And then developing the audit and record retention policies to meet CMS requirements as well. I don't remember what, do I have one beyond this? Yeah, I guess next steps. I put submit completed application. That's actually been done and completed. We're in the process now would be the finalizing the participant list. At that time then would be addressing any of CMS questions around the application. And then the hope would be to receive notice of acceptance and then execute the agreement, the participant agreement. And then create the board, appoint the manager, identify the CMO, QA/QI professional, and the compliance officer. And that's what I have now. It's again in its infancy, and we have not signed an agreement at this time, and are still contemplating that by September 6th, which is right around the corner, obviously. And I'll try to answer.
Yeah.
that anybody may have, if I can.
Thank you. Yeah, absolutely. And, you know, Andy and I are right there with you in terms of completing all the steps for the MSSP application itself. For those of you who aren't familiar, where CMS has everybody who applied for the 2017 program year in the middle of what they call their request for information process, which is where they're asking for clarification on structural components and participating providers. So it is a lot of work, and having been through it myself many times, I really commend you guys for going through the process. It's a long road, but one that's well worth it in terms of the kind of positioning it will, you know, really allow you guys to leverage moving forward. I know you guys are still in the beginning, and so I'm going to take an issue that you raised in your discussion, and I want to kind of put it to the group. This is probably one of the most fundamental challenges that groups have as they're coming together in this in these new models, and it's the question and the issue around staffing. Boy, it seems like more and more these groups and these networks need staff that just frankly don't even exist. New competencies, new content areas of expertise, new, you know, a myriad of skill sets. In some ways, the way that Andy and I describe it with groups is you have to find somebody who not only has all the kind of subject matter expertise, but is also comfortable working in a startup environment, because to some degree, that's what this is like. And I think Joseph touched a little bit on, you know, kind of going to the, you know, the model where you really look for a third-party partner. But I want to turn it both to you, Kendall, and also to the larger group in terms of when you start to think about, you know, putting these types of models in place, what have you guys thought of in terms of staffing and staffing infrastructure and administrative support? Because, you know, these networks and these projects take on a life of their own, and a lot of times it gets, you know, pushed onto existing staff. But I'm really curious to hear from all of you about how you have struggled with and attempted to resolve the staffing conundrum.
Yeah, this is Kendall again. That's actually a great point. With I'm just bringing on a couple of staff currently, but you're right. The how quickly projects take on a life of their own and becomes overwhelming and grows beyond kind of maybe the intent at times, or bringing on new staff, as I'm doing, it creates additional work for other people. Even though you're maybe taking work away from some, IT, it creates a lot of additional work for them, and administratively, it will create a lot of different things. And for us, for instance, it's because of what we're wanting to do with the transitional care and care coordination in general, is looking at probably having to bring on some additional either software or means for being able to document what we're doing differently than maybe what we're doing now. So it's really something that would seem fairly simple, in some aspects become very difficult in others. That didn't plan for.
No, I think that's a great point. How about other folks who are kind of grappling with this? How are you attempting to address this really important aspect of infrastructure development? I'd love to hear what some of the other, if you don't have any great solutions, at least maybe help us understand what some of your challenges have been. How about the folks from North Country, as you guys are thinking about the infrastructure around a new IPA? What have been some of the discussions that you guys have had around who might staff this? Are we looking at hiring people, sharing staff, for example?
I mean, I think that's a great question. You know, one of the things that was a deciding factor that we would not be the driving entity for the district was because of those infrastructures. One of the organizations that we were considering to kind of propose being a leading entity is much more established to be able to be used to doing some of the payment structure management. They're more already aligned to kind of have some of those infrastructures in place. For the IPA model itself, we're pretty much in the earlier conversations. Again, we have a lot of the infrastructure when looking at the geography, but our organization is relatively small, you know, including providers and frontline staff. We're only about 450 employees. And so the internal structures for those mechanisms are not inherently in place with us. And so the collaboration with a lot of these different smaller government agencies like social services and some of the behavioral health folks poses a huge challenge for us to decide who might be able to contribute to those structures. Also, I think my Chief Medical Officer is able to join us, Dr. Martin, and she has comments as well.
This is Cindy Martin. The other issue is paying for these positions. If you have a grant or a source of funding, it's certainly easier to hire positions. For us in our organization what we were looking at helping develop, we're not going to have sources of funding ahead of time.
Yeah, it's a really good point, because a lot of times the programmatic infrastructures are sort of, you know, reimbursed in arrears, and it does put a special kind of pressure on organizations that are looking to staff for this, and folks have to get pretty creative. I could ask Andy to pipe in on this as well. We do see a lot of groups looking to sort of share staff initially, compliance officers, chief medical officers, and even finance and administrative services. You know, we see a lot of examples of groups coming together and saying, okay, well, we're going to create small subcontracts for these functions until we're in more of a situation where we've got the ability to truly designate resources to help support that. One of the other challenges that we see is that it isn't always a set of skills that our organizations have that are needed, and sort of it almost feels like somebody who understands complex models of accountable care delivery and understands how to work with data and analytics and new contracting skills and competencies with different kinds of payers. It almost feels like you're in a search for a unicorn. This person maybe exists, but it's, you know, often a challenge to find out who they are and where they might be. So, I mean, I think we just see groups really looking at lots of creative ways of being able to bridge that. And then in some cases, having to develop those skills with the existing staff that they do have over time, understanding that out of the gate, these may not be attributes and competencies that you know, existing folks have. Andy, anything else on that from our experience that I'm not hitting on that you think would be helpful to kind of share with folks?
Well, I think one of the most fundamental challenges that we're seeing groups deal with really revolve around staffing levels for care coordination or other navigation type functions that they view as being critical to doing the work of an ACO, specifically helping high-risk patients or moderate-risk patients who have the potential to become high-risk patients avoid unnecessary services. And yet there are some good models out there, but this stuff, despite the ACO program now, I think I want to say maybe in its 7th or 8th program year, you know, I don't know that there is a definitive best practice for how to do that. That's the fundamental challenge with programs like pure shared savings programs is, you know, they don't give you that money up front. You have to earn it. Because of the mechanism by which you earn it, the payoff doesn't come oftentimes for at least, a year and a half, sometimes 2 years, and that's even if you were successful. So from a staffing standpoint, it's really figuring out how can we as efficiently as possible staff certain functions that don't have direct reimbursement mechanisms, in the hopes that those will ultimately result in enough savings such that we can justify having made those expenditures. That's one of the roles, and you heard with the Mississippi group that tends to be one of the roles of a third-party administrator. So that's another option for how to get some infrastructure support and people support up front if your organization doesn't have the funds. But those come with other trade-offs, like having to share some of those gains or share some of the decision-making with the group. But I think in most models we've seen, Amanda's dead on, it's a lot of the pure administration of a network like an ACO like this often get distributed up amongst the participating members, who are asked to contribute time and effort in that regard. And then some of the more clinically focused, really looking for ways to kind of justify the expenditure. Oftentimes those positions don't end up inside the ACO network, but rather outside. But yeah, I think that's a good discussion. Thanks for a minute.
Thanks, everybody. Any other last questions for Kendall before we move on to the last group from New Mexico? Okay. All right. Well, at this point, Beth, I think I'll turn it over to you and your team.
Thank you. Can everyone hear me?
We can.
Great. So this is Beth, and she's going to help me out because she wrote this up. And we don't have as much to share in terms of what we've accomplished and clarity of a concrete vision. So we heartily welcome input and advice from everyone on the call. I think everyone is much further along in having a concrete vision than we are. The goal of our group, and I should clarify, let me provide a little background. Preserving Access to Rural Care Task Force is a statewide effort that's from out of the New Mexico Hospital Association, which serves all of our rural frontier hospitals as well as hospitals in micropolitan areas. And that vision for that larger group is to figure out the future of rural hospitals for New Mexico. And we have the vision right here: create and sustain a viable rural delivery model built upon a culture of trust and collaboration and upheld through visionary leadership. Within that, we applied for SNAC funding for the 4 hospitals in the northeast quadrant of New Mexico, which I mentioned earlier on today's call. That group is using the SNAC grant to identify services that are currently not available in their communities and figure out collaboratively how to improve local access to those services in a sustainable manner. So that's really where our focus is. And we have access to Medicaid claims data from which we've been able to narrow the work down to telehealth. In New Mexico, telehealth is a billable service. However, because of the way the professional fee and the facility fees are paid, it's not sustainable in its current funding structure. So we're trying to figure out both if there's a high enough volume of services we can offer and if we can come up with a viable model for delivering them. And there is definitely agreement within our group that we need to improve access to these services. We're focusing on prenatal care. 22% of the births in the Medicaid data set we reviewed, 22% of the births in the Northeast quadrant were to women who had no prenatal care. Of the remaining 78% of the births, very few of them actually had all of the standard number of prenatal services or prenatal visits. And we have not yet assessed if they were the appropriate frequency, but I think it varies quite a bit. Next slide, please. So the shared services are the prenatal care and then the telebehavioral health. Specifically, within behavioral health, there are two gaps in telepsychiatry. One is, and this is a problem across the country for rural hospitals, they have emergency departments. Someone comes in, they've decompensated, they've had some sort of physical illness, usually as well some sort of physical crisis, and they come in and they need to be treated for their medical condition, but they also need to be assessed and possibly moved to an inpatient psych unit somewhere in New Mexico. And rural hospitals do not have psychiatrists on staff for the most part. There are some wonderful exceptions, but the vast majority do not. And they certainly don't have them on Friday night and Saturday night when people show up after driving drunk. So having emergency access to someone who can, via telehealth, provide an assessment, a psychiatric assessment evaluation, and then find an open bed somewhere in New Mexico and get that person there is one of the gaps. The other gap within telepsych is for someone who does receive inpatient services, some sort of residential services, when they return to their community, they have limited access to follow-up care, for example, medication management. And for that, they need either a psychiatrist or another provider who has prescribing capacity in their license. And so we're looking at the viability, the volume of need, and then how to create a model that's sustainable. We're focusing on the Medicaid population because 45% of New Mexicans are on Medicaid, and that is certainly true for the Northeast Quadrant. Partnerships, yes, definitely the 4 hospitals, and we are looking at partnerships in Albuquerque for some of the OB services. Ellen, is there anything you'd add here?
No, the only other thing that we had talked about was possibly teleeducation for diabetics.
Right, thank you.
Which we haven't looked into too much, but that's another opportunity.
Thank you, yes. And so we have some we've done an initial data analysis of diabetes in the Northeast Quadrant, uncomplicated and complicated, but we haven't gone through to see what kind of services people are receiving and how we could do it more effectively yet. Okay, and final slide, please. Type of network model. This is where we're behind everyone else on this call. We don't know. Clearly, it will not be financial integration. Of the 4 hospitals that are in this group, and there are 2 others that are not in the grant but are participating, one of them is part of a nonprofit health system. 2 of them are owned by their counties. 1 is owned by state government. Of the 2 that are quasi-related to the program, 1 is a investor-owned facility, and then Holy Cross is also county-owned. So there are very significant structural and political barriers to any type of financial integration. And when we look at clinical integration, they all have different EMRs, and that's the reality. So we know that we're going towards clinical integration, but we don't know how we're going to get there. And I would appreciate any input from anyone on the call on what our next steps should be. In terms of payment models, New Mexico is in an 1115 waiver, and we have 4 managed care organizations that handle about 77% of the Medicaid population, the rest being FFS through Xerox. We have a meeting tomorrow with someone from Medicaid to give them a heads up and get their advice on how we work on this. I personally, and I think I speak for the group in saying we have very strong reservations about different contracting arrangements with each of the 4 managed care organizations because it would be such a nightmare to administer. We want something that works across all 4 of the MCOs and FFS equitably so that we don't have to get hung up on who's got which payer and what are the intricacies of that of the service provision for them. Ellen, is there anything you would add?
No.
Okay. Does anyone on the call have advice for us on how we move forward, because we need it? Oh, I was hoping for something.
We'll we'll give it another minute and see, and then obviously we have some, we have some thoughts, but you get to work with us outside of it. So, anyone have any thoughts?
And that's an important point. Because we are SNAP grantees, we have access to contractually Andy and Amanda, and that is enormously beneficial. We wouldn't be anywhere close to where we are now without them.
So, since we're not hearing from others, I'll just make a couple of comments, and I think, Beth, unfortunately, these are things that we have already discussed, but at least we can give some insight to the rest of the group. I think we're really testing, or will be testing pretty soon, whether the types of clinical initiatives that you've defined justify or even require a network at all. I think that certainly everything that you've talked about feels like a pretty safe place to be from an antitrust standpoint. So that, that's not the only reason to warrant necessarily having a network, but it's one of them. Since so much of what you're doing is focused on improving outcomes, there's not a lot of use of this as an attempt to just to purely increase reimbursement for the same set of services. It's about doing something fundamentally innovative and different that results, in achievement of triple aim type goals. That alone wouldn't justify or require a network. I think where things will get interesting for you, and I think you'll really need to start thinking about network, is around how to equitably share in success. If there is a need to use a network as a pass-through financial vehicle for incentive payments or other types of payments that that this will ultimately lead to. Whether you need to use a network purely as a cost-sharing vehicle. So if there are shared staff, and it makes sense to not necessarily house those within any one organization, although certainly you could look at models where you would house them within existing organizations. That might start to push more down the lines of requiring a network. But I think the biggest one is if you're wildly successful, and that's of course our plan. We want to plan for that level of success. But if you're wildly successful and then wish to take this, to a bigger scale, potentially looking at other, comparable or similar projects or similar populations that you can look to collaborate around, then there really might be a motivation for driving these initiatives with the managed care plans through kind of a coordinated network. So if it's something that ultimately you try to take statewide, something you try to do with a high level of standardization, or something that you really try to do with with direct sponsorship of the state as an embedded part of its Medicaid program, then that might be the right time to look at a freestanding organization that serves as the governance, the financial pass-through vehicle to the participants, could even have a level of branding unto itself. But again, that's a potential, not a definite. So, certainly something that I think we're going to track with you as you continue to develop these clinical interventions that we are very excited about, by the way, and very hopeful are really kind of hitting that sweet spot, of the triple aim. Beth, can you talk about, you folks, we heard today from a lot of groups that I think are really, more on the primary care side of delivery. Hospitals, while already potentially fragile, have to be concerned that if you eliminate some of these unnecessary services, that's a scary place to be from a financial stability standpoint. Have you thought about at this point, and I know the answer to some of this, but I'd like for you to kind of talk with you. Have you thought about how this impacts or would impact certain players in the healthcare ecosystem, and how what those impacts might be?
I guess I think feeling of the group is this is a very frontier region that we're starting with. So it's very low population to begin with. The average daily census, upon which critical access hospitals and even PPS hospitals depend for survival, is already very marginal. What we're thinking about is where is the hemorrhage? For what services are people going into Albuquerque or other urban centers to receive care, whether that be inpatient or specialized outpatient? And how can we improve access to primary care and other services that hospitals have locally or create locally to reduce the travel effort and the costs associated with the provision of those services or the receipt of those services in Albuquerque? So that's really where we're thinking. And this frontier America is struggling with an aging and declining population. So the writing is on the wall, and that's why our members within the association ask for creation of this park task force, because they are well aware that the current funding model does not work, works less well every day. And so we are looking for an alternative payment model and a process to get there. Is that what you were looking for?
Yeah, and I think just it's great. We applaud the foundation for getting the safety net together, and there's a lot of things that are common across the 6 sectors of the safety net. But one that we see as a challenge where there are pretty significant differences are in this declining reimbursement, conversation. Whereas the primary care side is saying, we actually need medical home payments, we need shared savings opportunities to put to work certain concepts that we think will save the system money. The hospitals are in a slightly different position, which is we potentially stand to lose revenue as if we're successful in reducing the total expenditure on healthcare. It's the hospitals that really have I think more exposure. So this is an attempt to be a part of the value equation, if you will, in a way that might have a new, we're looking at, well, are there CPT codes that would be involved in these services? And if not, can we structure some incentives that make these services sustainable, right? But really having to find new ways of delivering care, I think is critical. And that's really what I wanted to highlight. So thank you.
Thanks, guys. We're getting close to time, and we do have some closing thoughts, but there's one other thing about Beth's project that I wanted to kind of highlight for the group, and one of the things that I think, from my perspective, makes it so interesting, which is this is a group of providers who came together and really drilled into some shared data that they had in order to focus on potential interventions. And I was really enheartened to see that groups that really are not contractually bound to do so are willing to really sit in a room together and deconstruct what their claims data is saying so that they can identify some opportunities for intervention. We often see that groups, as they come together, as providers come together, have a lot of reticence in sitting down and drilling into data. And I think one of the strengths of the proposed models that the group in New Mexico has really built off this commitment to really use that data to think about some shared strategies and to do so in a way that's been relatively transparent. So I just encourage you guys to really take that lesson from that experience, and in some ways, even though Beth feels like she's very far behind, I think that just the sheer exercise of going through that with the group really indicates a willingness to work together and to look at intervention in a way that is really population and value-based, which is what we're all trying to achieve. So I just wanted to highlight that. I think that's an important differentiator that we see with that project, and we really encourage you guys to think about how you work with not just your claims data, but other data sets as you're looking at different strategies with patients and the other stakeholders you're working with. So thanks so much, Beth. I appreciate it. Oh, looks like you had a few more. Okay, so some final thoughts for you guys. And just this is really encapsulates not only what we heard today, but really what our experience has been with all of you over the last 6 sessions. We really want to commend you guys that all of us, through the work that we're doing and that we've shared through this learning collaborative, are really seeking ways to expand access and innovate care delivery. And that is, if I haven't said it before, it's one of the reasons I love working with safety net providers is we tend to be very scrappy and innovative and creative in how we're going to meet the needs of our patients and populations. And I think all of your projects demonstrate that, that sense of innovation and creativity. A lot of us are looking to really expand our models of care coordination and look at ways to really scale that across patient populations so that we can be effective with maybe an initial group of payers, but I think understanding, and again, I think we're deeply rooted in this idea that with safety net providers, we provide care regardless of the payer source on that. And I know it's important to all of you as you're thinking about these models to not kind of artificially segment your patient populations by payer source just because that's what the system tells us we need to do. And I know that, you know, what we would encourage you guys to do is be thinking about how you think about care coordination that really spans payers. And that by and large, the predominant model that we've heard from all of you is this idea of a horizontal network. And as you guys are looking at developing that, just be thinking about how might that model need to change or shift in the future. What are some of the challenges that we might have with staying in that model? What are some of the opportunities and sort of defensive posturing does that bring to us as well? So this is from early on in our discussion, but we just wanted to just end the note on some reminders as you guys are going forward with this work. Remember, coming together in these new network constructs is something that many folks have done before you. Many of you are well underway with these efforts, and just wanted to kind of hit on some of the things that really will reinforce your ability to be successful in this. Being able to have early role clarification, who's doing what does participation look like in the formation of strategies and the development of the infrastructure? How do we define and build relationships with other networks that are out there? Because we know that even as we come together as networks, we're not doing so in isolation. So really thinking about what our relationship is to some of those other networks in our health ecosystem. Making sure, and I think Beth did a good job of talking about how her group has really been able to align priorities and expectations. They really used a data-driven approach to being able to identify and clarify this. You guys will have, depending on kind of what your goals and intentions are with your projects and your network, there might be other types of priorities and expectations, but the more clarity and the more alignment you can get on that, the higher chance you'll have of being successful and being able to articulate eventually a successful model. Making sure that the folks that are at the table understand what the various models are, what their constructs are, what the opportunities are, is important. It's important to level set and not necessarily assume that all of your potential partners are going to understand some of the nuances of network development. So really just continue to educate and learn from each other, go back to your groups and continue to work this out and mash it out until we feel like we're all on an equal footing so that we can really look at developing models that are, going to creatively allow us to meet our goals. Related to that is this idea of being able to build effective governance models and identifying, as Joseph and his group are beginning to think about, as well as Kendall's group, what are those participation requirements and standards, and how are we going to hold ourselves and our group members accountable to that? And again, really being able to use data as an important resource in how we do our planning and how we really engage with each other and other partners. and understanding that ultimately this is probably going to take some level of financial investment across the board. And I know we're up on time, so I'm going to move quickly. In terms of some of the mistakes that we see folks making, a lot of times there's just too much focus on the actual contracting relationships and not enough focus on being able to build that value proposition that your network brings to payers and health system partners. Another significant barrier can be this idea that you have a board that's so ginormous that it lacks efficiency and ability to really act, effectively as new challenges are being faced. So really look at what have you done in terms of your governance model and making sure that it's nimble and responsive. Poorly communicating with health center boards or other boards until you're too late in the process. So all of you represent organizations that have boards yourself. So as you're going down this path, make sure that you're really engaging not only the staff and the patients that you serve, but your boards as well. And then, making sure that you've really vetted your options in terms of legal structures and don't underestimate the amount of sweat, equity, and time this is going to take. And then, there's just a whole bunch of other issues that can present as you guys are going through this process. But more than anything, we don't want you to get discouraged. This is something that you're capable of doing. We've got great examples from the last several months of hearing from you and reading through your case study responses and listening to today's discussion. This is something that you're going to be able to effectively manage as you go through these transitions. Just stay focused on the variables that will really keep you aligned as you're moving forward, really focusing on those core, the core competencies and the core priorities that are going to make your network strong. And we know that as you continue these dialogues, it's going to be something that you're going to be able to really accomplish. Not all the conversations will be easy. Not all of the work will feel seamless, but it is something that you'll be able to accomplish. So on behalf of Andy, myself, the rest of the Starling team, who you didn't get much of a chance to interact with in this collaborative, we want to thank you. I'm sure that the folks at ASU are grateful also for your time and contributions to the process. And just know that, we are more than happy to continue to be a resource to you guys as you move forward. We know that ASU has a rich cadre of resources also to support for you, and you guys also are a resource to each other moving forward. So I'll just stop there and say thank you and see if Andy or anybody from the group or AJ want to say anything else before we close out.
That's it for me, Amanda. Thank you all.
Yep, same from here. Thank you, everyone.
Thank you from North Country.
Yes, thank you very much, Kern County.